Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. So let's start talking about treatment of metastatic disease. So no observation, no focal therapy, plus minus debulking nephrectomy. As you're all well aware, and how I describe it to patients is, listen, there's two sort of ways we treat kidney cancer. There's immune therapy and then there's anti-blood vessel therapy, I call it, right? And that's by and large the mainstay of our current therapy. We're gonna get to immune-based doublets, which are the standard of care. I think we probably all agree, but let's talk about monotherapy first. So Monty, are you giving anybody monotherapy? If so, which mechanism and to whom?
Yeah, gosh, it's been a while since I've actually contemplated monotherapy. The obvious setting is in a patient that has contraindications to IO, right? And in that setting, you're sort of tethered to using a bench.
And what would that be? What if it's like a little psoriatic arthritis and they're take methotrexate or,
Right. So I've actually been sort of burned in cases where I think it's just a little tincture of psoriatic arthritis, but I think that if they're on DMARDs, if they're on methotrexate and so forth, I generally stay away from IO. Yeah. The cases in which I might, sort of consider it are sort of minor dermatologic ailments, but for things like rheumatoid arthritis, Crohn's, ulcerative colitis, I'm staying away from IO entirely in that setting.
Do people agree? What's your personal threshold?
I would add a specific patient, because I've seen a few of those transplant patients too, because we don't have any data about the safety of immune checkpoint inhibitors.
Yeah, solid organ transplant.
So definitely.
And I have a few of those patients for sure. Moshe, how brave are you is really what it comes to.
So when it comes to the solid organ transplants, I try to avoid the immunotherapy. There are data for rejection of their transplanted organ. When it comes to patients who have rheumatoid arthritis, psoriatic arthritis, we're lucky to have a rheumatology team. So I basically get the rheumatologist on board and say, what are your thoughts? Is this something that's severe? A lot of those patients are on low doses of methotrexate and actually don't need to be on them. Yeah. So I think really the message for if a patient can get an IO-based therapy, whether it's monotherapy or combination in the context of an autoimmune condition, is getting the specialist on board to help with the decision making.
I find there's a lot of chart lore. Somebody was told they had rheumatoid arthritis 18 years ago when, I don't know, they don't, and somebody it's in their problem list, right? And
it's never going away.
It's never going away. I've had that happen. So I'm sorry, Monty, you were saying absolute contraindication to IO.
Yeah.
Then you'd give VEGF TKI.
Exactly.
Okay.
Exactly. And I can't think of too many other circumstances, frankly, but if I do see, that older, frail patient where, gosh, I just don't think that they're going to, sustain on a TKI, if I think they'd be really challenged by complications that could result and often do result from dual immunotherapy, I might consider giving single agent pembrolizumab. Dave McDermott put out really great data suggesting a 30% response rate in a very large series in Keynote 427, suggesting that approach has some validity. So, again, the median age of kidney cancer being 65, right? We do have those patients that come into our clinic at 90, 93, 95 is probably the oldest that I've seen, right, with metastatic disease diagnosed. Then you start having those conversations around how aggressive you want to be with therapy. And I have to confess, I've offered single agent pembro as my preferred choice in some of those settings.
I think it's reasonable. Shuchi, what do you think?
I agree with everything that Monty said. I'd also add, the Atkins data, that the paper that came out, the HCRN trial, and I was already using nivolumab or pembrolizumab, but that the 427 and also the Atkins data, I think they've consolidated us with now clinical trial findings that it's okay to use single agent, IO therapy in some of our frail, very 80-year-old patient who, won't pass. When I look at him in the clinic and he won't pass the eyeball test for toxicity tolerance,
That's fair.
It's interesting. I do use the contraindications to IO. I don't really use contraindications to TKI. So I'll give these patients an IO plus TKI. I'll give them axitinib and pembrolizumab, and I'll have just a low
coronary event a week ago.
Yes, there's always the severe extreme. But in general, even, I've treated 84, 85-year-olds with axitinib and pembrolizumab, and if at the first sign of any trouble, I'll just drop the axitinib.
Yeah.
But I see less of contraindications to TKIs, aside from whether the patient can handle it, in which case you can adjust or just drop it. But the response rates are so much better when they're given in combination that I like to try upfront to do it.
Yeah, I agree. And I've done single agent pembro in a couple of super frail patients. I kind of agree about the no real contraindications to TKI because you can control hypertension. I was joking about the coronary disease, but I saw a patient with like critical 3-vessel coronary disease last week. So that's the exception, right? Not the rule. So, okay, so not much monotherapy, I think appropriately.